Hey people, how are you doing? Welcome to episode 142 of the Sports Therapy Association podcast. My name is Matt Phillips, creator of OneShotLive.com, and as always, this episode has been recorded live at 8 o'clock on a Tuesday on the Sports Therapy Association YouTube channel. So in this 8th episode of our reflection series, I will be chatting very shortly with physiotherapist Emily Sweet, who will be reflecting on episode 229, entitled Pregnancy-Related Back and Pelvic Pain, that was recorded earlier in February this year with the wonderful Michelle Lyons, who, as you may have seen on social media today, is going to be one of the speakers at the STA Southwest Conference, which is happening in Exmouth this September the 20th and 21st, in collaboration with the ST School and Hands-On Hub. As you will have seen, tickets are now on sale at the @stschool.co.uk. There is a very generous, substantial early bird discount valid until the end of June. And also there is an STA member discount, which you can find out what that is if you go to the Facebook member page. And if you don't use Facebook, you listen to this on YouTube, then email in or check your STA newsletter emails. I think it will be on there. But yeah, find out and you get a little bit extra off, but it does have to be used before the end of June. So don't hang around. Get your ticket now if that tickles your fancy. There we go. Right. So before we start this week's episode, I must give a huge thanks to my last week's guest, sports massage therapist Hannah Tabram, who reflected on episode 87, Menopause Transition, Soft Tissue Implications. That was recorded as part 2 of our Women's Health Month back in February 2022. How can that be so long ago? With special guest Jenny Bowell of Bowell Education. It's available, as all of the episodes, on any popular podcast app and YouTube and at the sta.co.uk. So yeah, do check it out. And if you do, please leave a rating and a review. Right then, people who have joined us live are coming through the door. Just say hi to a few people. Nikki Mansfield says, evening, you're lovely. Can't say that, Nikki. It's a children's show, but nice to see you here. Angela Thompson says, hello, this is my first live STA podcast. Angela Thompson, thank you very much for joining us live. We hope you enjoy it. Do feel free to ask questions in the comments and watch out for Nikki Mansfield. Nikki Mansfield has come back. Oh, says, congratulations, Angela. Welcome to the Heckle Lounge. It's not the Heckle Lounge, Angela. This is exactly what I mean about watching out for Nikki Mansfield. But anyway. Cecily Hislop is in the room saying, get on my beauties. Oh my God, it's a little bit raucous tonight. Feels like I'm sitting watching the Crystal Palace game. Angela Thompson, brilliant. Right, let's just leave these comments now. We'll leave them to it. But anyway, if you have come in tonight in the live lounge, do feel free to ask questions. I have told Emily if she sees something interesting up there, then to cut me short and bring you in, because it is all about you guys who have joined us live to join in with the episode. So back to tonight's show, episode 242. Let me bring up physiotherapist Emily Sweet, who will be reflecting on episode 229, pregnancy-related back and pelvic pain. Hey, Emily, how are you doing?
Hiya. Yeah, good. Thank you. How are you?
I'm okay. I'm a little bit worried about our live audience tonight. I'm sure it's no slow on you at all. We just seem to have attracted some of the rabble, some of the riffraff have kind of come through the door, but that's fine. We'll treat them like any other individual. Nikki Mansfield says, that's me told. No, I'm joking. I love you all. Right. Thank you so much for joining us. Really nice to see you again.
Yeah, and you. Thank you for having me.
Well, you're a wonderful reflectioner because you were last here in December 2024, reflecting on Therapy Expo 2024, part of the panel there. So yeah, very keen to have you back for you to share your thoughts once again. Which brings me to my first question, because I'm happy that you are a physiotherapist, because we do get questions on the show like, do I have to be an STA member to come up? And it's lovely having you here, because it shows, one, that you don't have to be an STA member, and two, you don't have to be a soft tissue therapist. You can be a physio, chiro, osteo. So thank you for doing that.
No, you're welcome. Thank you for having me. You've released some such gems of information. So I am a key listener to everything. So it's great. Like, we all want the same information and we all want to learn. So I don't think it matters what area you come from.
That is my soundbite sorted out for tonight. So wonderful. We'll get that out on social media. I'm interested actually, and I will be asking you a few times because a lot of our listeners are not physios. They're not allied health professionals. And we've talked a lot about kind of imposter syndrome and the fear that if you're not an allied health professional, then you miss out on so much. But for example, reflection, is that something which as part of physiotherapy or course you were taught to do, to kind of look back and think?
Yeah, so actually, was it the first year of uni? So I've been qualified now for 4 years. So I'm still a baby physio, to be honest, early in my career. But yeah, going back to the first year of uni, our actual first module was on like reflective practice. So they do start it sort of right away. And as well, throughout our placements, it's part of our sort of criteria and like mark, I suppose, for us to provide reflections each week on sort of any patients that we saw, any conditions that we looked at as well, and for us to sort of look into the evidence base a little bit of that. But yeah, they do start it in uni and get you doing it really regularly, especially whilst you're on placement. So again, if there's any sort of students listening or anyone, to be honest, because reflective practice is so important because that's how you learn and improve. But any patient that was tricky or anything, just reflect on it and say what you learned from it, what you did well. If you were to see them again, so if you were to see someone that presented like that, what would you ask next time? Because then it just helps you sort of install those habits and also picking up patterns as well. It is installed into us quite early on, and then with the HCPC like registration as well, for sort of evidence of CPD, reflections count for that. So it's a case of if you ever got called up and you need to demonstrate what CPD you've done, if you're getting into the habit of trying to write a reflection, say maybe once every couple of weeks, or even if it's just like once a month on something that you've learned about, or you've had a bit of a tricky patient, then if they did call you up for it, then you've got all your evidence there anyway. So it's a kind of thing, obviously, for your own self-reflection, for you to keep improving, but also if you do have that call up, you're not in that wild panic like before.
That's true. I mean, sometimes it's good to have Big Brother watching. It's kind of healthy. In a lot of non-allied, well, I think in really all non-allied health professionals where there's no real need to be part of a professional association or organisation. You don't have to do it. It's not legal, but it's kind of cool if you are, and then that they're going to ask you like, "Where's your CPD for this year?" Because we need a bit of that sometimes.
I think as well, it's like it depends what environment you work in, but I'm like really lucky. I've got a brilliant team around me, and then I find that you're constantly reflecting anyway, because if you're chatting about, like I said, like patients that are a bit tricky, or you're like, oh, I've tried that, but it hasn't really worked, or just any questions, then you're constantly asking each other, oh, what would you do if you had this? Or, oh, I've tried this, but it hasn't really worked. You're constantly reflecting anyway. Mm-hmm. So I think if you are in a team environment, you're more than likely doing that without even knowing, which is a bit of a challenge if you are working on your own a little bit, because sometimes it's the same for me as you don't know what you don't know until someone does it differently or you've spoken about it. So that again is that prompt of you're doing things, and you've just got to keep reflecting, because then that's just how you're going to improve.
Very cool. Great advice. That's 𝐼𝐿 Physio, yes?
Yeah.
Team. We'll give them a shout out.
Team.
𝐼𝐿.
Amazing.
Not Isla, as I keep saying. It's 𝐼𝐿, but it's spelled ISLA. But anyway, great. And it's true. I think that's one of the problems. A lot of soft tissue therapists are by themselves. They might be renting a room, and they do miss out on that kind of, first of all, having people around them, and second of all, realizing that when you do ask somebody else, it's not embarrassing and they might not know the answer either, or just confirm that what you're doing is fine. The amount of times when I was younger, I was lucky to just be for 10 years in a team with physios, osteos, podiatrists. So any question I had at the beginning was like, oh, this knee, it's weird, it's dodgy, am I doing the right thing? And you know what, 9.9 out of 10 times, it's like, Matt, you're doing fine. Just keep doing what you're doing. You've done all the tests. There's nothing there. Just keep doing your loading and this and blah, 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 and it's fine. And I was like, yes.
Literally. And I think as well, that goes down to like personality traits. I think I'm that person as well, that I'm kind of, I'm wanting to, yeah, I'm like a people pleaser. So I'm like, right, I kind of, I want to do things right. And I'm sure with everyone else as well, you want to get the best out of your patients. So sometimes if things that you're doing, you're like, this isn't quite working or isn't quite fitting, you're like, they're relying on me here. Like I need to do my best to think of any other thing that I can provide and do with them. So yeah, sometimes as well at the start, you've got that, like, especially when I was starting off, and still to this day, sometimes I think, oh God, that imposter syndrome feeling. But that's why, yeah, you podcasts as well like this are brilliant ways that if you are working on your own, if you're listening to people, these podcasts, they're always talking about like case studies or ways that they explain conditions. You think that's brilliant. Next time I have someone that comes in with that, I'm going to use how they worded that. So again, that's a way of reflecting.
Excellent. No, lovely. It's really healthy. We could do a whole show about reflection. I think that'd be
Yeah.
great value, but maybe not tonight, maybe another time.
Yeah.
But no, really healthy to hear it, and great advice. And this is why if people are alone, then you do need some collaboration with other therapists. Just pick up the phone, go and visit each other. Don't see them as competition. It's like Andy Hosgood, who's going to be at the conference as well, is saying, collaboration over competition will always win. Don't try and reinvent the answer to something which someone down the road has answered already. Go and see them, have a cup of tea. Oh, look, like nice clinic, and you advance so much. So, right, let's put a little pin in the chat about reflection and collaboration. Apart from tonight's reflection, so I'm interested. Out of 240 episodes or so of the Sports Therapy Association podcast, you chose episode 229, pregnancy-related back and pelvic pain. With the wonderful Michelle Lyons. Apart from the fact it's Michelle Lyons, who obviously is a fantastic reason in itself,
Queen.
What else was it about that, the Queen? Yeah, what else about that episode in particular kind of resonated with you?
So it came such a right time for me when it was released. So sort of a year ago, I sort of like specialised in MSK outpatient stuff, and then within the NHS where I work as well, you then have sort of specialised rotations within MSK. So you have like women's health rotation, rheumatology, like burns and plastics, those sort of bits. And I really wanted to do the women's health rotation, which is great because I've got that confirmed for September. But in order to sort of go through that as well, we have competencies to be able to see pregnant ladies. And I was working through those from the beginning of the year, really, from Christmas and through. So it was just on my radar of obviously working through those and beginning to see pregnant ladies on my caseload. So that's why I really wanted to listen to the episode and pick this because obviously we do see it a lot. And I wanted to make sure that the way I explained things to patients was correct. I was obviously up to date with the latest evidence base. So I think I was kind of the perfect target audience for when she said, she was like, I just want to start spreading the word and getting people confident with talking about it. And I was like, that's me. That's me right now at the stage of my career. I'm starting to see these people now. I want to make sure I'm doing everything that I can to obviously be explaining things right and so being able to give them a plan, essentially.
Fantastic. So I guess then I'm interested when you listen to the episode, is there anything in particular which either stood out as something you didn't know, or if you prefer, something which you kind of did know, but it was nice to hear reinforced?
So it was really nice to hear that was reinforced around the infographic that I think that she said towards the end to sort of direct us to. So I have sort of like printed it out. If people haven't seen it, I mean, it's not the best, but I'll see if I can hold it up onto the screen because it's not very big. But essentially, it's the beliefs around sort of reframing pelvic pain.
Yeah.
Which, I knew about those anyway. But the main message is that it's safe to move, that your pelvis is stable, and that it's self-manageable. So that was really nice to hear it reinforced. Again, in that they're stepping away from that approach that it's sort of hormone-driven. And as well, it was good to like know that a lot of women actually have it. So I wasn't aware that 75% of pregnant ladies have it, because I was just new to seeing these patients. But it is really, it's really prominent. And it sounds like from the podcast in the past, a lot of pregnant ladies haven't had it explained to them, and like the reassurance provided for them that it will get better. And I think the biggest driver that Michelle was saying was that hope. So like right away, the first thing I want to say to people as they come in, it's like, it's okay, we can do something about this. We've got a plan. And I think that was the biggest takeaway that I got from it, is just reinforcing those messages of belief, of hope. It was a first big step for them to even come in and have an appointment, because it can be quite scary and nerve-wracking, because they think they might be alone and that they're the only people who feel it, and that they've got sort of something wrong with them. But actually we can be like, no, the evidence says 75% of people who are pregnant have this, and you can just really layer that to make them feel empowered, and that they can manage this and they don't have to deal with it alone.
It's really interesting listening to you saying this, because you know what, I'm putting myself in the position of a patient who's pregnant. It's not easy for me, but I'm trying to do it. And I'm feeling like you know what you're talking about, and I'm feeling calm. I can feel my shoulders going down. And I'm wondering whether, because the fact is you haven't had children. No.
No.
You're a woman, so you're closer than me in that sense. But some people might think, have you ever thought yourself maybe that, I haven't had kids, and even if they don't know I haven't had kids, I know I haven't had kids, and so what right have I got to tell these people it's going to be okay? Has that crossed your mind?
Literally, and I think as well, not only with patients, but also like my people who have taught me about this topic and going through things with me, because they have all also had children. And so when I was learning about this and all of that, it was kind of not like they would assume that I know, but a lot of the terminology and things for me around like questions that we would ask, I'm like, God, I don't even know what that is. Like, I haven't gone through pregnancy. I don't know how the body changes, or it's that thing of, you want to try build as much rapport with your patients as you can. And like you said, Matt, like being a female, they automatically think, yeah, she's gonna know. So I think as well, that's why I really wanted to, educate myself as much about it, because I can't go back on past experience, because I don't know what it feels like to have a child. And the people who were sort of chatting me through it and teaching me essentially would you say things and just be like, oh, you know what that means. I'm like, no, I don't. You're gonna have to go through it with me. I haven't been there, I haven't done it. Like that, I think that was a thing, first of all, building that confidence, really, because you don't have that experience, like self experience through it.
I guess in reality, though, a lot of issues which you deal with, whether it's something to do with somebody who's had a hip replacement, or they're suffering from a particular injury or stress fracture, or whatever, you probably haven't been through it, and yet there we don't kind of feel so paranoid. But when it comes to something this kind of big, we're kind of like, oh my God, inside. But it's no different, really, is it?
I know, and I think it's just the thing of, oh my gosh, you have a child growing inside of you. That's what makes it scary, I think, because you're obviously thinking about you want to look after the mum, obviously, but again, I think all the past beliefs around exercising when you're pregnant, because it's going to impact the baby and everything like that. So you are also, I think that's maybe why I was feeling, a little bit anxious and things, because not like I have two people. Well, you do. You are thinking about two people as well, and obviously
or maybe
the mum
more.
is.
Who knows?
Yeah, exactly. Like, and that's the biggest thing on the mum's mind as well, isn't it? Like she loves that baby or babies, and you just want to make sure that she feels so confident, because she wants to do what is best for her and her babies.
But I think that's where and from listening to you, I think you've already got it, because sometimes you can, when I feel kind of safe listening to someone, then it's normally because of the way they're talking, it's because of their hand gestures, it's because of the pauses and the reflection and stuff. But I think that's the principles of coaching, isn't it? If you're a good listener and you
Mm.
just reflect and summarize, and you don't just offload a load of information like, didn't you know this? And I saw this on Michelle Lyons'
Yeah.
podcast, and did you know? then regardless of what that human being in front of you is going through, it doesn't matter if you haven't been through it yourself. Empathy
Mm.
comes from just listening and reflecting and letting that person know that you are listening and that person's free to talk, and you're not judging, basically, isn't it? So I think that's what
Yeah.
hopefully makes it a little bit easier.
I think as well, like, it's obviously talking a lot about like pain science sort of education, that actually it's, the nervous system is upregulated, it's the sensitivity in the tissues, and we talk a lot about, that element of reducing that pain amplification, trying to calm the nervous system down. We talk about that with loads of other patients, say, that have like chronic low back pain or anything. So I'm like, no, I know I can talk about that topic, and you can apply that to like pregnancy related back pain, that it is that sensitivity, the upregulation of the nervous system, that actually, pain is real, it is completely real. And you definitely, that's another really good point that Michelle was saying, that, yeah, you don't want to just say to people it's all in your head. We need to let them know, yeah, we hear you, it is, but actually just sometimes those signals for your pain, they can just be a little bit off. Sometimes that dial can just be turned up a little bit, and we want to explore ways that we can reduce that, because sometimes those threat signals just aren't accurate, if that makes sense. And we do that a lot with all of our patients anyway. So yeah, why is this patient population different in the sense of discussing those things? And when we chat to patients as well, we're always wanting to know, that their hobbies, their lifestyle, what things they enjoy, what things they do to relax, all of that. And this can be applied exactly to this population as well. Yeah, and rather than focusing on, I suppose, like, what, I think it was a really nice thing where she was saying, like, rather than thinking of like what are the issues, is why are these coming about? And if you ask why, that then goes nicely into sort of picking up the drivers of that sort of pregnancy related pain, which, yeah, she did list off. And I think the drivers that you have anyway, actually, when you're just conversing with the patient, you pick up a lot on those things anyway, when you're finding out, the social history, if she has any other children, is she working, so is that job dissatisfaction, like, factor to it. And as well, yeah, if she has any other children, then Michelle was saying, like, obviously you've got sort of reduced capacity, like you're not going to have as much sleep, so that your energy already is like your resilience is lower, compared to if it was your first pregnancy maybe. And I think we're brilliant at being detectives, so I think we anyway, just through chatting to the patient, you get all this information anyway. And I think then when Michelle was chatting about that these are the drivers for it, you think, oh, I actually was picking up on those things anyway, and then it sets you off quite nicely of where you want the conversation to go. Or okay, she's not sleeping as well, maybe let's focus on chatting to her about sleep hygiene or things to do to maybe try and improve her sleep. Yeah, those sort of bits, if that makes sense.
Oh, massively. No, really, really well summarized.
Yeah.
And it's so nice to hear, you reflecting and picking up on those things. Yeah, no, wonderful. I mean, you made, two really important points there. The one where Michelle says that one of the biggest drivers is having had a baby before.
Mm.
And I think, I just imagine, because we've got somebody who believes it's because of the hormones, because of relaxing, it's because of this, they've got an unstable pelvis, they're feeling insecure about their body. if you can plant the seed, not just offload it, but if you can plant the seed and give them a little bit of kind of reassurance that actually the fact you've got another child, you're not sleeping very well, this is to be expected. Yeah, your body's strong. It's just we have to do something about these. And I love the analogies you use with kind of the dial and stuff. And I love the way you reinforce it. It's not all in your head, because that's a really important thing, which maybe, we weren't quite so good at kind of 8-10 years ago. So no, it's really healthy stuff, and it can make a massive difference. And also the other thing Michelle said, which you remind me of, is that one of the biggest predictors in helping women without pregnancy, if they've got related pelvic girdle pain, is giving them the belief that it will get better will help. Just that, and that sounds so crazy, doesn't it? But it
does. That's the thing. It sounds so simple, but clearly something that just hasn't been said enough. And I think it was the sort of the belief that we can help them really reinstall that hope. Like anxiety and stress is another thing as well. And again, that's something that I sort of routinely ask anyone, because we know with sort of like, your yellow flag factors and things, and we know that I sort of explain it to patients that if you have a sort of a lot of your unhappier hormones in your body in terms of like your stress levels, if you're not prioritizing things that are going to help you relax or things that make you happy, so getting those feel good hormones in your body, then those unhappier ones of stress and anxiety, again, do the opposite effect. They sort of dial things up. They dial up that sensitivity, when actually if we can really help try relax, focus on things that you enjoy, trying to make time for yourself, and going sort of down the other way and getting those things that are going to try help relax or make you feel a bit better, again, it then dials things down. So that's another thing that we talk about to sort of any patient that is in in pain. Actually, we can apply that to this population as well. And I think so she was talking about sort of factors of like weight management and smoking. Again, that's sort of part of your pillars of health. So you'd be chatting to them about, again, any other sort of population. And the reason for those is that it sort of increases that inflammation, which again will just dial up that sort of tissue sensitivity.
Excellent. No, amazing. You're a physio, so obviously your red flags back to front. Yeah. So I mean, because that's something which I know our listeners are going to be adds to their worry and their anxiety of what if I miss this? What if I miss this? So I wondered, as a physio, what are some of the kind of red flags which we do have to look out for, because we mustn't just get too blasé and say, oh, don't worry, it's just because your kid's keeping you awake. What are some of the things we need to keep an eye out for, and what are some of the symptoms which should flag that?
Yeah, so I know Michelle highlighted sort of two of them in the podcast. So one of them was sort of DVTs. So it's sort of really important that you're going to want to screen for sort of any redness, any heat at all, just really trying to get those questions going. And, I would just ask, how does it feel down below? Essentially it's trying to get rid of that taboo, isn't it? And if they do say yes, it's just knowing where to escalate and who to escalate that to. So again, I would always say if you're on your own, then you're going to want to definitely get them to sort of the GP. So it'll be either like writing a letter to support, or just sending them through there, because you definitely want to get that stopped or highlighted as soon as possible, those warning signs. But again, if I was in like where I am now, like a team environment, if they were sort of saying yes, I'd be like, oh, do you mind if I chat this through with someone else just to double check? But you're going to be wanting to screen for those. And also,
that's a really interesting point, because like DVTs, our audience are familiar with, because on any course you're kind of told about the DVT, but obviously any DVTs you're told about is look at the calf, look at the lower leg. But what you've said, because people are going, oh, DVT, I'm familiar with that, they're feeling a bit better. But obviously this is a taboo area, because you're talking about potential DVT, and the swelling could be on the labia or something, which people don't even want to say that word. But I think Michelle mentioned this was the importance of asking if the person's been for a visual. Has somebody actually looked at this? If you've got the
Yeah.
symptoms of, and that should be easy enough to do, shouldn't it? You just have you had anyone check it out and have a look at it like GP?
Yeah.
So
Yeah.
important, signposting, isn't it?
Exactly. And sort of the other one as well was that don't know if I pronounced it right, but that transient osteoporosis.
Sounds
I
good
want
to
to say
me.
transient.
Transient sounds
I
great.
think.
Yep.
But again, I think because that can appear as sort of pain in the deep groin as well. So obviously very sort of common with your anterior pelvic girdle pain that they could be coming in sort of to see you with around like your pubic symphysis area. But what I got a lot from that was it was more as well sort of asking her history. So has she had REDS in the past, so relative energy deficiency, sort of any like eating disorders, potentially. Does she have low bone density? Has she had any previous fractures before? Has she ever taken any steroids? Alcohol use? Yeah, so those questions, if they, if she had said yes to quite a few of those, and I think it would raise your suspicions a little bit more. So yeah, I would definitely dive into a little bit more about her past if you're querying this as well. But I think it's that sort of, again, it would be that unremitting pain, which would be really, really sore on weight bearing. So I think if you have those two factors, she can't settle. There is no comfortable position at all. And then once you start diving into a little bit of our history and ask around those sort of questions, if she's sort of answering yes to any of those, then yeah, I would think, yeah, we need someone else to be involved here and have a look.
Brilliant. I'm sure that sounds reassuring to me. I hope that's reassuring to listeners as well. It's classic stuff which you'll probably all be aware of with other parts of the body, like sudden pain, unexplained pain, swelling, all that sort of stuff.
But there are sort of a few others to sort of be aware of as well. And I think if she came in to see you, you'd want to know if there was any sort of abnormal vaginal bleeding at all. So yeah, always asking that. And again, if there is, then sort of where we are, we like in sort of the NHS department, then we would sort of send them down to triage. But again, I would get them on the phone to like their midwife, or again, just escalating it, because then that's sort of like, this isn't a physio or sport therapist or sport bath problem now. We need to get someone else involved to just check this out. So I'd always ask in sort of around that. Any sort of preeclampsia as well. So that's sort of like your blood pressure. They're going to want to know about that. And it's mainly sort of asking around these questions of, have you had your midwife appointment? Like, are you a midwife-led pregnancy, or are you consultant-led? That's always quite a good question to ask, because if they are sort of consultant-led, then again, that could be a reason why, because they're potentially a bit more complex. So it's worth asking that. If they've had any history of sort of any spontaneous miscarriages in the past as well, that's worth noting. Just to add to their history, are they anemic? Are they epileptic? It just adds to that complexity a little bit around the pregnant population. And if they have like any sort of low-lying placenta, so I think it's called placenta previa as well. So again, that would be just some signs if there was any sort of like early warning labour, because like your cervix would open prematurely. And as well, it's always just good to see what are the fetal movements like. Is the baby kicking as regular? Is it normal, or has there been any significant reduced fetal movements? And if that was a yes, again, I would think, right, yeah, you need to go on and chat to someone about this. But they're sort of our specific questions we ask on sort of our like antenatal sheets, or when we see them in the NHS. So I think that's a good thing for people to be aware of.
Yeah, that's good. So I was thinking, like some of these questions could be on a kind of a specific kind of PARQ questionnaire.
Yeah.
But if not, there are ones which, as you listen to your client during the subjective, you need to start picking up with and just guiding the conversation for them, giving them a chance to come out with the fact that, this is happening and they haven't done this. And I was a bit worried because I'm not bothering to see so-and-so because I just haven't got the time and I'm too busy. And yeah. And I love the way that you're kind of hopefully empowering the listeners to make them realize you're not dealing with this. It's not in your scope of practice. You just giving them a chance to reveal these flags themselves, and then you signpost them to say, you know what, probably worth doing this or going to see so-and-so, which is lovely.
Like again, it's just that detective work, isn't it? You're just essentially, it's that screening. And it's just because if they were sort of answering yes to those, one, that's the priority, isn't it? Like mum and baby health is the priority. And also you're just like, oh, maybe is this something that we can help with, or actually that is what they just need to go sort first off. So I would always sort of ask about those, and again it just depends how much depth you want to go into it, but just checking if they've had their regular scans, and just essentially at their mid appointments and things, is everything going as they would expect it to, essentially.
Great stuff. And I think it's probably, we've talked about this a few times on the show, but women, unfortunately, maybe because of our patriarchal society, whatever, are kind of put into a position where they think I should just deal with it. It's just typical. This is some pain. It's going to hurt. It's pregnancy and stuff. And they kind of maybe downplay and don't want to bother somebody. They don't want to be that person who's nagging. But I think this is, we've had Alistair Beverley on the show a few times, and he kind of signposted the fact that diagnostic overshadowing, which is where they might have gone to see a GP who's kind of gone, it's just because you're pregnant. It's because this and that. Don't worry about it. And unfortunately, if someone else had presented with these symptoms and they weren't pregnant, then they would have kind of been flags for further investigation. So I think sometimes a lot of women don't want to kind of make too much of pain they're feeling. So how do you distinguish that uncomfortness of being pregnant with something which needs to be investigated, like the 75% of pelvic girdle pain you were mentioning?
I think you don't want to just be like, oh, this is just because they're pregnant. So I would still have your sort of your differential think about your differentials of, you'd want to check if they were saying about symptoms going down the back of their legs that are presenting maybe a bit more sciatica or nerve irritation, then you want to have that as a differential. Again, like you said, you don't want to just reason everything because they're pregnant. And I think that's, again, when you sort of get the subjective history. When did it start? Actually, has this been going on before they were pregnant? Their onset could have been like a year ago or 6 months before they were pregnant. So actually, is it pregnancy related, at that point? Or it could be a combination. Now you had some other issues before, maybe had some hip pain before, and you didn't really ever get it sorted, and now you've become pregnant. And if you had pain beforehand, then again, we know that that sensitivity of the tissues already sort of goes up, so that dial's already up a little bit. So I think it's, when you go into sort of your more subjective assessment, is doing it exactly how you would anyone else, in the sense of knowing when it starts. What are their aggravating factors? What are their easing factors? Does it fit with your sort of your pregnancy related pelvic pain? Or are you thinking, actually, it could be sort of more my differentials? Do I maybe need to do a neuro assessment because they're reporting pins and needles, they're reporting numbness? So I know that's, and I find that really hard because I think I can see a bump. I have a pregnant lady sat in front of me. It must be because of that. But actually, sometimes I do just have to think, no, I'm just going to go for it, ask my questions like I would anyone else, see what the answer is, and does that sort of fit in with the pregnancy, if that makes sense?
No, totally. Yeah, no, it's really cool. No, definitely, you have got to not just put everything down to the fact they're pregnant, but also give them permission to kind of just say they don't think this pain is actually normal. It's more than they, because they might just not they might, for a lot of our massage therapists, they may just come in because they want a massage to feel good, to get away from things for maybe the only hour they're going to have in that month. But this is where you have a little chat and say, this pain you're talking about, is it kind of just come and go, or is it kind of continuous? And then open up with these questions of, have you got any swelling, or have you got any of this and that, and blah, blah, blah. And then discover something which they're trying to just not bother anyone with. I think that's part of it, isn't it?
And I think like the soft tissue stuff as well that you mentioned, and I know Michelle was saying about like with manual therapy, that actually I loved the way she said it was like, oh, it's like like conversing with the nervous system. And I was like, that is so nice. I really like that. I'm going to definitely take that, because again, it was just that thing of explain to the your ladies in front of you that it's not to become reliant on this it's any sort of manual therapy is not there to realign you or make your pelvis stable. Those messages don't want to come across at all. It's actually, if this is something in our toolbox that we can use alongside sort of the education and exercise, and if that's going to help, I think it was, she was saying, if we can calm things down first and then build them up. So actually, if the massage and things is going to help settle that nervous system down, make them feel comfortable, make them be able to feel ready to engage in the exercise, and that's what we want to add in, if it's appropriate, to then allow us to build on that so they feel happy to sort of do exercise and things. But it was just not to become reliant or send the message across that we're doing anything to their pelvis at all. It's fine how it is, but actually if it's just going to help reduce that sensitivity a little bit, then it can be really helpful.
Very cool. Very cool. And this is such a good example, I think, of interdisciplinary kind of care of massage therapists looking after, because somebody else, maybe a women's health physio, has kind of said, this person's really wound up and decent. What did you say? Conversing with the nervous system. They need some of that. And just working together. I mean, that's what people need. So great stuff. Right, we could talk all night about this. It's always the same with these great topics. Sarah Jones in the comments, I have noticed you. Sarah Jones says, so late, had to squeeze in a run. Hey, you know me, that's a great excuse, Sarah. It's fine, you're forgiven. Nikki Mansfield has also been supportive, saying, oh, it's a good one, Sar. Emily's amazing. There you go, Emily. For starters. And I'm definitely going to go back and watch the original episode. Sounds like I missed an absolute Lions classic. Yeah, it is one of the Lions classics, one of the 4 I think she's done. Sarah says, awesome, I'll catch up tomorrow. That's brilliant. That's what we want to do. We want to kind of help people who have missed out one of the other episodes to go back and listen to it. So nice one. Good job. Angela Thompson says, I do a group workshop for non-complex PGP within my support role in pelvic and obstetric physio. Mostly information and exercise components. Some really nice peer-to-peer moments in the group setting. Great. We love a bit of communication. Amazing. It's good to hear, Angela. Fantastic. We couldn't finish this episode without talking about Michelle's favourite topic, constipation. She just wouldn't. I would have an email within 5 minutes. So what are you going to say about constipation, and why is Michelle super vigilant?
So again, it's that taboo subject, isn't it? And I think it was more at the start of the episode. She sort of used the example of when we're sort of screening for cauda equina and things, that we ask all those red flag sort of scary questions, has there been any changes to your bladder or bowel movements or anything like that? And if they say yes, you're like, oh God, I've got to do something about this now. And I think it's the same thing, that we just need to get confident with asking about it. Because as well, if we don't maybe give them the open space to say about it, then that they won't, and they may think that, why am I like this? Am I the only person like this? If they haven't asked me about it, is it important? Is it even relevant? So I think even just asking the question, again, it just opens up that field for them to talk about it. But I got sort of the key things to take away from that is, again, going back to sort of basics around asking around the hydration of everything, and as well your pelvic floor muscles are very heavily linked and connected to sort of your stress levels. So again, if everything is really, really tight, and again, we all know how horrendous it is if you feel constipated. It just makes you feel awful anyway. So again, if you have that, and then you're on top of, lack of sleep, the pelvic pain, you can't do anything that you used to enjoy because it's so painful. It is going to be one of those things that again is going to add to that, what amplifies your pain system. So yeah, we definitely just want to ask about it, because as well we can then suggest things that can help. So yeah, keeping up with hydration is like the biggest one, and as well, it probably seems like a really simple idea, but like even if they are going to it and they're struggling, that thing of like getting them to have a stool so then they raise their legs up, so again it just makes that bowel movement feel more comfortable. That could be an absolute game changer for somebody, but they just, because no one's asked them about their bowel movements or anything, again they just haven't thought about their position on the toilet. Yeah, there are a couple of those bits, and I think as well it's a like, on reflecting, it's something that I want to again learn more about around it, because before I listened to this podcast episode, I was one of those people where I would probably, have you had any bladder or bowel changes? And I've probably been a bit more focused on the bladder side of things because of like your pelvic floor in terms of leakaging and all of that. I was kind of more on that. I think it's great because it's got a lot of not screen time, what I'm trying to say. A lot more people are talking about it now, sort of, bladder leakages and things, and that is something that people say is like a bit of a passive comment, when you're pregnant, like, I'm needing to go to the toilet more and everything. So I think urinary stuff is spoken a little bit more, and I thought that was kind of a bit more of the important part. But actually, after listening, like you said, Michelle was talking so much about bowel movements, and I thought, this is something for me where I need to do a little bit more listening and reading into, so I can feel more confident with asking questions. But I think the first step for me was actually just opening the floor to it, and a couple of simple things that I know I can talk about around hydration, and maybe some positions that might make it feel a bit more comfortable. And if I need more help, then that's when I'll go and ask my my other colleagues and things, of what things do you find is helpful for constipation and things.
Great. Yeah, it's a wonderful example, isn't it, of taboo topics and things you shy away from. But I think what you said at the beginning as well, just letting that person know that it's very common. Okay, they don't have to not talk about it, because I think it's just them and it's embarrassing. It happens loads, and if it happens loads, there's probably things which can help, because when lots of people have got this going on, there's going to be kind of solutions. So, and I like the point Michelle said about actually preparing you for birth, because if you can help this person Michelle puts it wonderfully. But if you can help that person have a healthy, happy bowel movement, then that's going to reflect later on when they're actually giving birth, because they will have already worked out ways of just relaxing and looking at their breathing and looking for a position which is going to make things, and not just putting up with it. So, no, good on you, Michelle. We like the fact that you are
channeling this.
Yeah, that's very cool. Right, well, look, it's 8:49. I try and make these. I always say I try and make these shorter, but it's such a great topic, and it's been such a pleasure listening to you reflecting on it. So thank you for that. Really appreciate it. And there's so much more in there. You know what? The thing with Michelle Lyons episodes is, I've made some notes down here, and there's so many other tips which we're not going to go through now, but revolving around positioning and pillows and scar massage and shoe size and bra fitting. It just goes on and on and on. Looking at balance, there's so much, isn't there? She just drops all of these.
I think all those little bits, I was like looking at more of a definitely took away. It was more like a whole body approach. So again, even though they've come in to you with low back pain, actually there's so many other things that we can work on that is going to help. And I think that the conversation around strength training, that actually that max contraction equals max relaxation, and you don't have to be focusing on just, like, any movement is good movement if it makes them feel good, and we're it's non-threatening to the nervous system. So again, they're just feeling at ease, feeling comfortable with movement. But yeah, it doesn't always have to be focused around the lower back. Actually, I think she was saying, if we're getting our foot muscles involved, or our calves, or like rotate cuffs, or doing some upper body work, some rows, because those are still stabilizing muscles. Again, if they're sort of, it's just for your body to then learn what it feels like to contract and relax, and you don't have to focus on the muscles just around the back, which I thought was a really good takeaway as well. Because you were saying when you have a big, you can't see your feet like when your bum's got big. So it's again just keeping in tune with your whole body, which really good. And advocating for that sort of strength training and keeping moving, and just trying to reduce that sort of upregulation of the nervous system, trying to find ways for them to move in a safe and comfortable way, essentially.
Great stuff. Okay. Right, everyone. Thank you so much for joining us live. For people who are listening, including you podcast listeners, we have been reflecting on episode 229, pregnancy-related back and pelvic pain, that was recorded early in February this year with special guest Michelle Lyons. If you are interested in courses about what we're talking tonight, Michelle Lyons has got something for everyone at celebratemuliebrity.com. That includes her online female hormonal health masterclass, which has got 3 separate modules into menstrual health, maternal health, and pelvic girdle health. She's got the menopausal health course with the 3 big life stages: exercise, library, manual therapy, pathophysiology. Loads of information. Go along to celebratemuliebrity.com. Not only is it great information, it's just put forth as only Michelle Lyons can. So, and like we said before, Michelle will be at the STA Southwest Conference as well. So check out the stschool.co.uk. And for details on that, tickets are on sale Saturday the 20th and Sunday the 21st of September later on this year. There is an STA member discount as well, so make sure you're using that, but you've got to use it for the end of June. But that'll be in the members area. STA members. Right then, thank you, Emily Sweet, physiotherapist Emily Sweet, for your reflection. Really appreciate it. Thank you so much.
Thank you for having me on. It was brilliant. Really good topic.
If people want to follow you, which I'm sure a lot of people will now they've heard you, where are you most active? You're on Instagram?
Instagram, that's where I'm most active. Yeah, so it's at 𝐸SweetPhysio.
Simple, 𝐸SweetPhysio. And then we've got Isla Cell Physio as well, which is ISLA.
That's it. Yeah, I was just going to get her handle up as well. So that is at Isla Cell Physio.
Very organised.
Very easy to remember.
Brilliant. Thank you. Next Tuesday, 8:00 on May the 27th. Yes, that'll be right. My reflection guest will be clinical massage therapist Jessica Janneman of Ease Therapies, who's going to be reflecting on episode 222, a therapist's guide to hypermobility, that was recorded in December 2024 with special guest Bonnie Southgate. So if that is of interest to you, then join us live if you can. That'll be next Tuesday at 8:00 on the Sports Therapy Association YouTube channel. And thanks again, everyone who joined us. Cecily Hislop, you're not riff raff, Cecily, you're lovely, I'm joking. She says, thank you both, some great insights. And Sir Glenn Murphy, MBE, has said, Emily was fabulous. Well done. There you go. You've just been congratulated by a knight. Is a sir a knight? Yes, he is a sir. So there you go. Bucket list, cross that off.
Thank you so
Wonderful.
much.
Thanks, people, for joining us live. Really appreciate it. And thanks for sharing questions and your acknowledgement of the great Emily Sweet. Really appreciate it. Right, people. Take care. Hopefully see some of you live next Tuesday at 8:00. But until then, as always, take care of each other. Bye-bye.